Thanks, Joel, and I want to thank Ryan and Ben and other Ben for the opportunity to be here. I think it's a fantastic opportunity and one that we should have more often. Everybody's told you what a great operation periacetabular osteotomy is, and that's absolutely true. But there's a downside, and that's what I'm going to talk about now, and that is what do you do when things go wrong? Because it's a very different population. And these patients, many of them are, for want of a better term, dealing with some type of post-traumatic stress because they've been sold an operation, which is big, a big recovery, and then they have at least suboptimal, if not catastrophic outcomes. So the emotional side, I mean, these patients tend to become part of your family if you're doing it right, because you don't make the decision to proceed unless you know them well enough to know what's ahead. Disclosures. So the objectives are relatively straightforward: indications, planning technique modifications, and then a number of case examples. And no two cases are the same, although they do share a common deformity, which I think everybody here has already talked about as far as the biggest issue with malposition. And that is retroversion. And these are egregiously retroverted cases. I mean, it's hard to believe that anybody could leave the operating room with some of these x-rays. And yet, some of them are relatively recent. In the early days, maybe we didn't know better, but at this point in history, the appearance of these x-rays are really quite mind-boggling. All right, we'll start with this worst case first. This is a 20-year-old that was operated at a large, well-known Midwest university, and at this point, 18 months out, she's had a PAO, a revision PAO, and a proximal femoral osteotomy, and this is her x-ray. So we're going to come back to this later. She also has had extensive workup. She has a partial superior gluteal and partial sciatic nerve injuries with significant muscle weakness. So what are the treatment alternatives? And realistically, the only thing we can talk about in most of these cases is revision. There's a rare case with subtle retroversion where you might consider a femoral osteotomy. I haven't seen that case yet. Acetabuloplastics, slightly retroverted, taking off normal anterior rim to make up for your deficiency. Not a very appealing idea. And then most people wouldn't want to put an acetabular component in a severely retroverted acetabulum. So I think that's probably out as well. So ultimately, we're back to PAO revision. Imaging is everything that we normally think about, plus I don't think I would do another one of these, even if I was forced into it without a model. Now that models are cheap, plentiful, and you can get them out of material that you can cut and reposition. But you definitely need three-dimensional modeling, and you should be able to play with it enough so that you understand where your osteotomies are going to be physically oriented, and you can plan for that intraoperatively. I have not yet had to change surgical approach. These are late cases, and so you can, even with scar excision, and I think I've always excised the scar just to make a better wound closure, not for cosmesis, but for basically wound healing. I can always get the skin closed without tension, and if unlike trauma, you can get away with flaps in these cases. So if you have been given a bikini type incision, you can still go down the tensor sheath with a modest flap and start off. So the best place to start is always, for me, an intact anatomy, which is posteriorly along the crest. So we don't know what happened at the anterior part of the crest. I'll start in the back, and then I'll start distally in where I think the tensor sheath is. And then I'll move toward the middle, trying to find the nerve, assuming a nerve is intact. If it's not, well, you've got that going for you. Modifications, excise the scar, find the lateral cutaneous nerve. You want the retroperitoneal iliofemoral interval that we always have, but it's not easy to get there because there's a lot of scarring, and it may be periarticular all the way down. The rectus head may have come off. You may find yourself in the joint early without recognizing it, depending on what was done previously. I try not to go laterally. I think sometimes you'll have to, though, just because of the scarring, and you need a mobile segment to work with. I've done a case where I developed the neurovascular interval to get a better view of the quadrilateral surface, and I've had one case where I did essentially an AIP or intrapelvic approach from the midline to come back and look at the quadrilateral surface as well. I don't think those are usually necessary, and I probably could have gotten away without it. You don't chase broken screws, take off the heads, unless they're in a critical area, you just go around them. You need better ideas of where you are because your anatomy is distorted, so use guide wires or drill bits, not 2mm drill bits, but big drill bits that don't break. And then you're going to need more image guidance than usual. And so you want to go slow. You're going to try to always use the non-union site. And if you've got a sclerotic, healed, innominate cut, then I will typically go above that where the bone is softer. And even though everybody's talked about doing a prophylactic posterior column screw, I've never had the judgment to know when I'm going to do it, so I always end up doing it after the fact. Fixation, you usually want multiplanar fixation. I know that's a difference of opinion depending on how you were trained, but for these cases, I think multiplanar fixation is important. And usually more robust, although not always. Grafting, if you've got an atrophic non-union or a gap to deal with, and you can graft, and you usually have adequate local sources so you don't have to go somewhere else. So if these are the normal cuts, and they're not quite the cuts that I make, in these cases, you may want to extend this. Now, John has already pointed out, dealing with a small articular segment, it may be very advantageous in the acute setting where you have a very mobile segment. But in a large case, a late case like this where you're dealing with difficult mobilization, a bigger segment is advantageous. So I'll move up to the crest. Not that this fragment is going to stay here, and Brett's already showed you what this sort of sliding triangular graft goes into the innominate osteotomy after you're done, so it doesn't stay there. But you need to be able to, this is the only cut where you really are given any leeway, because the posterior column quadrilateral surface cut is so narrow, you have a very small corridor. Same thing is true for the pubis and the ischium. When we started, it was always, we were looking at the pediatric cases that were done and came to us as adults. And so what we saw were Salters in the upper right or some Chiaris. And so we reported a series. It was 10 cases. There were 8 Salters and 2 Chiaris. And our results were equivalent to the primary series. And I said, oh, this is no problem. I mean, this is a relatively straightforward operation. If they've had this, with the exception of what John's already mentioned, that is, if they've taken the crest off and you have the abductors and tensor recessed, they have a permanent gait problem. And there's not much we can do about that. So we looked at that, and so I felt that was great. And so, one of those cases was this was one of my, I think, 1986, one of my first 10 cases. I got this. There's a previous Salter, nicely done, but missing periphery of the innominate bone for the graft. Not a huge defect, but quite weak. And this is then also highly anteverted. And so this is her at, I think, a late follow-up. I just saw her back, I think in about 2000, last time I saw her. Basically, she was happy enough with revision of that to come to have the other side done. So I had a false sense of security about how easy these were. All right, so then we move on to periacetabular osteotomies like this one, which is, again, a small articular segment, highly retroverted with a pubic root hypertrophic non-union. And this is one of my first posterior column fractures where I put a screw in after after the fact. I should have known in advance, but anyhow, that's history. So this is what she looked like here and then at 8 years she came back to have the other side done as well. So considering the ordeal of having a primary and a revision, wanting to have the other side done, you have to be happy that the patient is convinced enough that she's improved enough to warrant another major intervention. Again, this is pre and post-op. It gets worse when they have a non-union. So here's a segmental non-union of the pubic root and through the posterior column as well. The articular reorientation is probably not as big a problem, except that if you look at her, she's short. This is almost like a triple that John just showed you. So, and how do you make up for that? Well, I wasn't able to, so this is where she ended up initially, and I don't know what I was thinking. Trying to control the posterior column for the front, but we didn't want to do a posterior approach yet. So we tried it, so the joint healed, but she still had the non-union, and that was, she was symptomatic. And so we went ahead, secondary approach, went back and plated the posterior column, grafted it, had a lag screw, and this went on to ultimately heal after she broke the plate. Again, but I think a well-repositioned joint segment, and then moving on to the other side as well. This woman was a Cobra pilot in the Army, and she was due for promotion, but she had hip dysplasia and had to have a military discharge so that she could have her hips done. And this is what she got out of that. Now she can't even sit in any kind of standard chair, let alone fly a helicopter. And this is relatively recent. And so, where do they come from? I'm not sure, but they're still being generated out there. So this is the initial appearance afterwards. After both sides, we did the left side first, and she was happy. We did the right side. But she had a massive labral tear, and these are a period of time when I was doing almost everything open through an anterior arthrotomy. I could not get posterior enough, and she also was anteverted, and I think she needed, for congruency, an adduction intertroche. So this is where she was after the first stage. And we subsequently went back, I think 10 days later, to complete surgical dislocation, completed the rest of the labral repair, and then a adduction derotation intertroche. This is what it looks like on the femoral side, sort of testament to the difficulties of dealing with a trochanter off proximal segment in terms of dealing with this segment. So she had fixation, healed, implants out at, I think that was about 7 years. This is a 17-year-old female, very tiny, weighed about 90 pounds. She had, I think, relatively straightforward dysplasia. She came in with this x-ray afterwards and said, oh, actually, this is stage 1. So she was told then her residual pain is that you have a non-union, so we're going to fix your non-union. So the non-union was plated, and she still hurt. And then so after an extensive evaluation discussion, and a little bit of difficulty getting that plate off, considering where it is, we had to go back and do anteverting PAO. Again, posterior column fixation, tiny, tiny skeleton, and a pediatric plate for the proximal femur. And then final x-rays, I think it's 6 years. All right, back to this young lady. Fortunately, I didn't think this was going to happen, but after we get our plane review, this is a held view, flexion and abduction. So she actually is remarkably concentric. And after that imaging, we had a long discussion about what to do. She'd already talked to several total joint surgeons that had no interest in even thinking about, you can imagine the problems with total joint arthroplasty in this patient. So salvage is really all we have. So this is a case that I'll never forget. It's about 14 hours of total surgery. But she was anteverted after the proximal femoral osteotomy. So I'm not sure exactly what was done with that osteotomy. And then as far as a small joint segment and loss of periphery of the innominate bone, this is where the proximal cut was made. You can see sort of the cleft from the posterior column, so I could find that. But after implant removal, we did the pelvis first, and then came back and did the femoral side. So this is at 1 year, and this is at 5.5 years. Is that a great result? No, I mean, she's a chronic pain patient. Her family has come apart during this period of time. She has a congruent joint. She's had some motor recovery. But this is a catastrophic outcome equivalent to basically anything you can imagine as far as a malignancy in this woman's life. And so I think it just is paramount that if we teach people to do these, that they are in a supportive enough environment that they don't put themselves in a position of ending up with one of these cases on their own. And then the last case, which is not a revision PAO, but I've had seen 3 of these. So this is a 22-year-old female. We had this operation. Looks pretty straightforward. Maybe get criticized, maybe slightly too anteverted. And here she is at 2 years with intractable pain. And we've gone through the sequence of how to analyze it. And if you look at it carefully, I mean, if you look at the acetabular obturator line on the right and match that to the left, there's something in the inferior part of the joint which is problematic. And you can sort of see an early inferior osteophyte. And the CT was showing basically an intra-articular osteotomy, which is healed with a focal inframedial arthritis. And this is what it looks like on CT. So she's got this very small area of the joint involved, and the rest of her joint is in good condition. So this is perfectly amenable to a surgical dislocation, as we did, basically resected that low anterior horn. And she's done well overall, although she's certainly not completely asymptomatic. I think this is at 2 years, and she's now at 8. Outcomes. This is the only real significant size series, an anchor study of 11 centers and 34 patients. So you can imagine how frequent this occurs. And the less frequent it becomes, the better off we all will be. The average follow-up was 2.5 years. And it was a very detailed analysis of functional outcome and pain. And there's a statistical significance done in the best of hands where they're improved, but they're nowhere near as good as a primary. 2 of those patients had an early conversion to a total hip. So summary, extensive preoperative planning and discussions, technical modifications, and it's still worth doing, but with the expectation that it's going to be nowhere near what we want out of the primary operation. Thank you.